All right, ladies and gentlemen, we're going to get started again. And first presentation this afternoon is by a visitor to ACOEM. He's not an occupational health physician, but rather a journalist and an editor. And not only a journalist and an editor, but a Pulitzer Prize-winning journalist and editor. So he is in rarefied atmosphere in that area. I asked some of my colleagues who could best talk about government and labor with respect to the history of occupational and environmental medicine over the last century or so, and Jim Morris's name came up. He has won more than 70 awards for his work, including the George Polk Award, the Sidney Hillman Award, 3 National Association of Science Writers Awards, and 5 Texas Headliners Awards. He directed a global investigation of the asbestos industry that won the John Oakes Award and in environmental reporting from Columbia University, and also an IRE medal from the Investigative Reporters and Editors. He's also led projects on workers' hazards in the oil industry that relate to air toxics in particular, and that won the National Prize Foundation, Harvard University, and Hunter College. And in April 2013, he received the Poe Award for national reporting from the National White House Correspondents Association for Hard Labor, a series on health and safety threats to American workers. He helped edit Breathless and Burdened, which won the Pulitzer Prize 2013 on federal black lung benefits program. He also conceived and was the lead writer on the 2014 series Big Oil, Bad Air, a collaboration with Inside Climate News and the Weather Channel that garnered 10 national awards for its revelations about toxic air emissions from hydraulic fracking. He's worked with a number of newspapers in Texas and California, as well as on publications such as the U.S. News and World Report and Congressional Quarterly in Washington, and we're very pleased to have him speak with us today. I'm going to pull up his slides. That should just take me a minute. So I get onto this. Let's see. Jim, which one is yours? It's this one, isn't it?
Let's see.
It's April presentation?
Yes,
yeah. That's it. All right. So we'll get you going here, and I'll take the thing off, and then just click that, or else do that.
Okay. Thanks very much. Bob, thanks for introducing me. Thanks for having me here today. Before I start my presentation, I just want to explain a little bit about the place I work. It's the Center for Public Integrity, which many of you may not have heard of. It sounds like a think tank or an advocacy group. It's neither. It's one of the oldest nonprofit journalism organizations in the country. I think we're about 26 years old now. And what we do, I come from a newspaper background, as Bob mentioned. I've been at the center a little over 6 years this time around, and I run the Environment and Labor team, which is a team of 7 people, myself included, ranging in age from 24 to mid-50s, a variety of skills and reporting backgrounds. What we do, we tend to do what we call deep dive investigations, very data-intensive, data-driven investigations that can take 3 months, 6 months, a year and a half, things that newspapers used to do a lot more of. So we feel that we fill that void. And in the last couple of years, what we've been doing more and more with a fair amount of success is partnering with mainstream outlets. You heard Bob mention the Weather Channel. We've partnered with almost anybody you can think of, from ABC News to NPR to you name it, basically. So when we have a big project or a big story, rather than just put it on our website, which doesn't get a lot of traffic, quite frankly, is not a destination website, if we partner with NPR or some other outlet, we're going to reach a lot more people. We're going to reach millions of people. So I just wanted to let you know sort of what this place is, since you're probably not familiar with it, or maybe you are. So, all right. So I'm going to start my presentation now. I hope I can get through this. All right. So I'm going to talk basically about the work that I have done on occupational health and safety the last 38 years, almost that whole time. I've always found ways to do worker health and safety stories. It's something that I'm very passionate about. It's something that I think is grossly undercovered by the media. And although there are projects here and there you'll see in the Times or some other publications that are quite good, I just feel there's a need for sort of ongoing coverage. So I've stuck with it after all these years. The gentleman you're looking at there is named Chris Johnson. Chris is 41 years old. He lives in upstate New York. On paper, he has about 4 years to live, although you wouldn't guess that from seeing him. He looks like a pretty healthy guy. Chris has acute silicosis, which is the product of one extremely dusty 5-month job that he did as a bricklayer back in 2004. The Center for Public Integrity profiled him in the first installment of a series that we called Unequal Risk, which ran last year and also which ran on our site last year and also ran on slate.com. So I'm going to try to play a little video clip of a piece that our reporter did on Chris.
I love stonework. I love laying blocks, I like laying bricks. I pretty much love it all. My brother is a welder, also a mason. My 2 uncles are masons. My cousins are masons. I just figured I'd fit right in. Well, it was one particular job that was up in Rome, New York, and we had these big brick buildings, and we had to remove a lot of the damaged brick and replace it with newer brick and cut expansion joints into the building.
If you look at this building, it's just a big red brick apartment building. This is not an unusual material, it's not exotic. It's something that everybody is around, but the people who cut through it or work with it are susceptible to getting disease from it.
I was losing a tremendous amount of weight. I was out of breath. It took me a lot of exertion just to do simple tasks.
For this kind of silicosis, there's no medicine that you can get people to make it go away. There's no radiation therapy, there's no chemotherapy, there's no antibiotics. The problem is that the air sacs in the lungs are filled up with this thick material so the air can't get into the body.
We sat down with a surgeon, and the surgeon pretty much told me what the outcome was going to be for the odds of me living and passing with a lung transplant. And I didn't want to put my family through that, because it wasn't very good odds.
So we chose to profile Chris because his life story tracks almost perfectly the federal government's decades-long effort to tighten the silica exposure limit, something, as you know, it finally accomplished last month. As you can see from this photo, which one of my reporters took just last spring, some workers, and apparently their employers, are still oblivious to the risks of silica dust. The new rule issued by the Occupational Safety and Health Administration should help with these sorts of situations, but obviously it's not a panacea. I think there's a bigger problem that needs addressing, and I think that problem is the way this country has decided to treat workers differently, and that is, I would say, more callously than the general public when it comes to protections against toxic substances. Here's a startling figure that I suspect many of you already knew. According to the best estimates, more than 50,000 people die each year from workplace exposures in this country. That's about 9,000 more people than died from suicides, 15,000 more than died from motor vehicle accidents, 20,000 more that died from falls, and 34,000 more than died from homicides in 2013. Why is this number so high? In part, it's because the Occupational Safety and Health Act of 1970 treats even egregious violations, which lead to worker deaths or serious injuries, as misdemeanors at most, less serious in the government's eyes than many environmental or financial crimes. I think that sends a very strong message and not the right message. But here's another factor that may be more relevant to this group. Only 470 of the roughly 84,000 chemicals made or used in America have OSHA exposure limits, and only 208 of 2,238 high-use chemicals have limits. Worse, most of the limits on the books are hopelessly out of date by OSHA's own admission. This is a graphic that one of our people showed. It's probably a little hard to read from out there, but it shows that how many of the limits exceed the 1 in 1,000 cancer risk. So because these limits are either don't exist or are so hopelessly out of date, that can lead to situations like this. This is a photograph of a Goodyear chemical plant in Niagara Falls, New York. It's one of the most striking and I would say best documented workplace disease clusters in recent history. More than 50 cases of bladder cancer have been tied to a chemical called orthotoluidine, which is used to keep tires from cracking. The National Institute for Occupational Safety and Health began investigating this cluster in the 1980s and found that exposures to the chemical were, in NIOSH's words, quote, well below the legal limit of 5 parts per million. That limit, like many others, hasn't changed since OSHA adopted it in 1971. So how did we get to such a bad place? That's the question I sought to answer when, a couple of years ago, I began digging into files at the National Archives, as well as the Nixon and Reagan presidential libraries, and interviewing people who got into the worker health movement in the 1960s and 70s. What emerged was a fascinating and troubling story of OSHA's very rocky start, a brief period of productivity in terms of controlling toxic substances in the late 70s, and then decades of near stagnation since. This is George Gunther. He was the first head of OSHA, the enforcement agency created by the Occupational Safety and Health Act of 1970. I'm sure Mr. Gunther knew the job would be challenging, but I'm not sure he knew just how big a hornet's nest he was walking into. I looked at his personal papers at the Nixon Library last year and got a taste of what he encountered. Here's a letter, here's a 1972 letter from a man in Seattle to John Ehrlichman, who was then still employed by the White House, complaining about, quote, un-American and, quote, socialistic workplace health and safety regulations. Quote, I am astonished that a Republican administration would have enacted this legislation, close quote, the author wrote. And this was one of the more measured responses to OSHA. An employee of an oil drilling company in Wyoming wrote to one of his senators that the new law, quote, reeks of the Spanish Inquisition and the German Gestapo, close quote. As I say, it was a very rocky start. Still, there was some reason for optimism. The very first citation OSHA issued in 1971, so this is citation 1, dated May 28, 1971, used the so-called general duty clause of the Act to rebuke Allied Chemical for allowing mercury to accumulate in dangerous amounts at its plant in Moundsville, West Virginia. People who worked on the OSHA legislation told me they were certain the clause, which is a catch-all provision that says employers must provide a workplace, quote, free from recognizable hazards that are causing or likely to cause death or serious harm to employees, close quote, would be used in cases where specific chemical exposure limits didn't exist or obviously weren't protective. There was another reason for hope. Unions like the Oil, Chemical, and Atomic Workers, which is now part of the Steel Workers, and the United Rubber Workers, whose members were dying of chemically induced diseases, were pushing hard for stricter standards and tougher enforcement. They complained publicly in the mid-'70s when the Nixon and Ford administrations insisted that health and safety rules be screened for economic impact. By the time Jimmy Carter took office in 1977 and named Eula Bingham, a professor at the University of Cincinnati, head of OSHA, momentum for a war on toxic chemicals in the workplace was strong. To that point, OSHA had regulated only a handful of substances. For many others, it had merely adopted voluntary limits, known as threshold limit values, published by the American Conference of Governmental Industrial Hygienists in 1968. Bingham and Labor Secretary Ray Marshall made health a priority. In 1978 alone, OSHA issued standards for benzene, arsenic, lead, cotton dust, the pesticide DBCP, and acrylonitrile, which is a chemical used in plastics. 2 years later, it came out with a generic cancer policy that would have required employers to control exposures to known or probable carcinogens to the, quote, lowest feasible level. The idea was to bypass the chemical-by-chemical rulemaking process that had proved to be excruciatingly slow and ineffective. Industry howled. The American Iron and Steel Institute warned that the policy could cost businesses $1 billion a year. Union officials urged OSHA to hold its ground, noting that the old way of doing things wasn't working. By 1979, the Labor Department was estimating that at least 100,000 Americans a year were dying of work-related disease. One official called it a, quote, massive but silent slaughter, close quote. Under Bingham, OSHA commissioned edgy films that were shown in union halls and other settings. Here's a clip from one from 1980 called Can't Take No More. Hope I can get this started.
We came out on strike because of the inhumane working conditions, but people was being misused so badly.
We're fired up! Can't take it no more! 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 We're fired up!
Occupational safety and health is a major social concern of the 1980s. These people are part of that movement. They are asserting their right, now written into law, to a healthy and safe workplace. This right has had a ragged history. It's not always been recognized. Work has killed millions. They've died from explosions, falls, electrocution, dangerous machinery, from breathing in poisons in the air. Millions more have been mutilated or permanently disabled at work. This year, it's estimated that up to 100,000 people will die from job-related injury or disease. Over 5 million will be injured at work.
Then came an election. By 1981, Carter was out, Ronald Reagan was in. Eula Bingham was replaced by Thorne Octor, who owned a construction company in Florida and embraced Reagan's limited government philosophy. The cancer policy was put on hold and quietly disappeared. Standards on cotton dust and hazard communication were also frozen, but ultimately went through. Quote, if we had had 4 more years, the chairman of the National Advisory Committee on Occupational Safety and Health under Carter lamented in an interview with me, quote, we would have really protected the American public from a variety of hazards. In 1989, under the George H.W. Bush administration, OSHA made a final bold move. It set or tightened 376 chemical exposure limits in a single rule, drawing legal challenges from both industry and labor. 3 years later, an appeals court vacated all the new limits, saying OSHA hadn't demonstrated that the old ones posed significant risks to workers. OSHA went back to its one chemical at a time approach to rulemaking. The outcome was predictable. Until the silica rule went through this year, the agency had managed to issue only 2 health standards in 14 years. In 2013, it put out a remarkable press release saying most of its exposure limits didn't protect workers and that employers should consider voluntarily adhering to stricter ones, either recommended by NIOSH or enforced by the state of California. In many ways, it was an admission of defeat. That brings us to the present, when many thousands of people in America die each year still from workplace exposures, not merely because of weak OSHA standards, but because of this country's oddly insensitive attitude toward workers. I think it's an attitude of, you signed up for this, too bad you got sick. It's infuriating to me personally, and I've encountered it a lot in my 38 years as a journalist. So for this reason, we tried hard last year at the Center to show the human toll of occupational disease. I think one of the most effective pieces we did was an 11-minute video, I'm not going to show the whole thing, about a young man named Chris Penny, who developed mesothelioma after pulling telephone cable housed in asbestos cement pipe underground. Here's a clip from our interview with Chris last August, which was the day before he had major surgery in Baltimore.
I can remember it just like it was yesterday. When I was going to work, I was already feeling a little lethargic, and I got an orange juice and I drank it, and it wasn't even probably 30, 40 seconds later, I felt like somebody stabbed me in the stomach with a machete. And then the doctor came in and said, "Chris, I fixed the rupture. I took a sample of the cancer, and you have a stomach full of it. It's stage 4 without question." He pretty much told me that I needed to get my affairs in order.
And then here's a clip from a deposition that Chris gave just 2 months later. If I can. There we go.
Chris is at home now. He is in very guarded circumstances medically. He had an incredibly invasive surgery, terrible complications from it, and spent weeks in the hospital.
That's the incision they had to make for the emergency surgery because of the infection.
He's had additional complications and hospitalizations since. But he's at home now with his family and doing his best to try and get his strength back.
I only have short bursts of energy, so I really have to think about every step, like I have to premeditate.
In terms of Chris's health, I remain hopeful that Chris will respond to the surgery, respond to the chemotherapy, and have as much good time with his family as he can. Other than that, only God knows.
Chris is still alive as I stand here today, but September will mark 2 years since his diagnosis, and all of you here know what that means, that he probably doesn't have a lot of time. I have just a few final words, one for this group in particular. We would not have found several of the key characters in our series, Chris Johnson, the bricklayer, Chris Penny, the gentleman I just put up there on the screen, without the help of occupational physicians. These doctors took the trouble to speak with us at length and to reach out to current or former patients to ask if they'd be willing to do interviews with us, which we greatly appreciated. And so I'm going to close by urging everyone in the medical field to do the same if you're ever contacted by a journalist. I'm always happy to hear from people on the front lines of public health. If you think you have a story worth telling, a story that the public should know about, please reach out to me. I'm going to give you my contact information right there. And we can take tips anonymously, however you want to do it, but we need people out in the field to tell us what's going on. If there's some new workplace disease, if there's just any sort of public health issue, that's our core focus on my team. So please feel free to reach out to me. That's what I have. Thank you.
We have 5 minutes for some questions. If there are questions in the audience, we don't have a microphone in this room. This is being recorded, so I'd ask Jim, once the question is asked, if you could just repeat a synopsis of the question.
Oh, sure.
Into the microphone for the recording. Any comments or questions?
It's interesting that you presented a case of acute silicosis, which is largely regarded as an obsolete disease, doesn't occur anymore. And it's notable that the cost myth, all the bridge episodes in the 30s, which resulted in some 700 deaths with acute silicosis. There have been a few since then of offshore oil rig workers who were sandblasting the rigs. Mm-hmm. But it's really, I teach at University of Pennsylvania. Part of my pitch is that acute silicosis is essentially obsolete. And this is interesting, but it's not obsolete.
No, far from it. This gentleman was exposed in 2004, and as I mentioned, it was just one job, one very dusty job that led to his disease. And I suspect there are quite a few more out there than we realize. He was in construction, and as you probably know, the construction silica limit until last month was far weaker than the general industry limit. So I think the feeling among doctors that we've interviewed and other experts is there are probably a lot more Chris Johnsons out there that we don't know about. So it is surprising.
You have a microphone now. Any other questions? Pete?
I'll just shout it. The expose of Wayne rather, Enterprise with the New York Times a few years ago also, I think, demonstrated that risks are being concentrated in fewer and fewer industries and more disadvantaged populations, so that the problem of occupational safety in particular, and health as well, is going, if you will, down the socioeconomic scale and out of sight to the majority of Americans. Do you think that's an important factor in the lack of response until the current to turn things around?
I certainly think that's part of it. One of the first big projects I did on silicosis back in 1992, 24 years ago, I was at the Houston Chronicle, and I documented some clusters of the disease among mostly Latino sandblasters out in West Texas and in the Houston area. And they got sick and they just disappeared. They went back to Mexico or Central America. Nobody ever heard from them again, and sort of out of sight, out of mind. So I think that absolutely had something to do with it, yes.
Any other questions? I'd like to thank you very much.
Thank you.
Very helpful to address us here. I'm going to introduce the next speaker. Otherwise, you're going to see the whole. Well, I'm going to introduce you here first. Don't put your thing up quite yet. I'm glad to see that we've still got a fairly sizable room full of people, and thank you for staying. I'm Bob Orford. I chair, until this year, the History and Archives section of ACOEM, and Judith McKenzie, who's in the back, is taking over effective this year. She played Alice Hamilton a little earlier today. We've had 4 sessions now on history, and I know some of you have been through all of them, and I appreciate the fact that you've done that. There's a lot of background in our specialty. My disclaimer, apart from saying that I don't have any financial relationships or pharmaceutical issues on this, is that what you see is what you get. There was a famous photographer that many of you know of, Diane Arbus, who said, "A photograph is a secret about a secret. The more it tells you, the less you know." And I think that that's true of presentations as well. As we listen to these presentations today, they're like lenses that talk about other times. And our own experience and our own understanding of these other times is different from perhaps the person that gave the presentation. So if what I say isn't quite matching what you might believe or have heard or understand, well, this is coming from my understanding, and that's really a disclaimer. So I'm going to talk about professionalism and ethics. Professionalism is something that has interested me for a long time, and I was glad to be able to apply at least some of my understanding here. It's going to talk about education, training, and research that relate directly to that, then the organized medicine role in occupational environmental medicine, and finally, some of the medical professionals who shaped our field in the United States. Now, there's a lot more that could be said internationally. We heard a little bit about that yesterday with Ramazzini and others, but I'll be focusing primarily on the United States. So what is professionalism? You have to start to think about things. How would you define professionalism? What is it? Why is it that people recognize us as being professionals in occupational medicine? Well, first of all, it's knowledge, expertise, and secondly, it's our willingness not only to have that knowledge, but to be willing to take action to use that knowledge. And finally, the ism part relates to principles or a doctrine that is adhered to. In other words, in some ways, you could bring that forward to today and talk about guidelines. The word ist is a form that is used in the designation of many medical specialties. Cardiologist, for example, although we don't quite have an ist for occupational environmental medicine. In some ways, it would be nice if we did, although I'm not sure we'd want to have the ist as in the psychotherapist. It's one word, George. So the American Board of Internal Medicine a few years ago came up or had a task force on professionalism and defining it as it related to internal medicine particularly. And so they asked people, well, what do you think professionalism means? And they came up with this word scatter that you've seen used for other definitions as well, which I thought was instructive in some ways. So I looked through this and came up with a couple of concepts that are particularly important in defining professionalism. One of them is education or knowledge, which you see in the yellow on the slide. And the other is ethics, which I think is a very important thing for professionalism, and particularly with respect to occupational medicine. And we'll come back to that very shortly. But the ethics I'm going to start with is something that wasn't really well defined in occupational medicine until much more recent years. But the AMA first came up with its ethical statement over a century and a half ago, in 1847, when it passed its first code of ethics that was updated in 1903, 57, 80, 2001, 2006, and is again being updated today. So if you go to the AMA website, hopefully you are a member, and I would encourage you to be members of the American Medical Association. The House of Delegates, which is the supreme entity within AMA, is currently grappling with updating its code of ethics. We had hoped to finish that process earlier this year, but for a variety of reasons it's been delayed. People have finally gotten through to read the revisions and have found things they don't like, and so it will be open for comment for at least another 6 months. But the code articulates the enduring values of medicine as a profession and states as a value the integrity of practitioners and the authority of practitioners to self-regulate. To a greater degree than exists in medicine as a whole, ethical conflicts are common in occupational medicine, and this results from the employer-employee relationship between the employer and the people who work for the employer as producing the goods and services, but also between the employer and the employee, who is the physician, the occupational health physician, who then forms that triangle and has to serve the employee of the employer and the employer at the same time. And obviously how you do that is going to necessarily create some conflicts for you. So the Industrial Medical Association, the American Occupational Medical Association, and ACOEM have all successively developed and produced codes of ethics. I'm aware of the ones from 1976, 1993, and 2010. I believe there may have been one before that, although I do not have the date of that one at the moment. The ACOEM Code of Ethics most recently was updated and published in 2010, and it was incumbent upon me, of course, to take a look at this in preparation for this presentation, and I noticed on the ACOEM website that it says peer-reviewed by Robert R. Orford, M.D., so I thought that was an interesting statement on the website. I was president at the time that was put in place. By the way, in terms of biography, I'm a former speaker of the House of Delegates with ACOEM, past president of ACOEM, and currently, and for many years, have been working at Mayo Clinic, currently in Scottsdale, Arizona. The International Commission on Occupational Health, which I'm also a member of and have been very active with, currently on their board as well, has a code of ethics that conflicts to some degree with the ACOEM code of ethics. And in the question period, I may ask Dr. Guidotti to expound a little bit more on that, because he was involved with the ICO code of ethics at the time he was on that board years ago and has a lot more knowledge about it than I do. But it was originally published in 1992, updated in 2002, and again in 2014, relatively recently. Education and professionalism in the field of medicine generally started, I'd say, with the Flexner Report. Now, it existed before that. I'm talking specifically about American medicine. And as was shown on some of those slides you saw earlier today, there was a lot of bad medicine, if you will, going on. Remedies that really were totally ineffective were being sold. Physician training was inadequate. Many of the doctors that were going out practicing surgery were not adequately trained. The people that were doing medicine really didn't have a great understanding of what they were doing in many cases. And so it was really Flexner's report, which was funded by the Carnegie Foundation in the day, that put medicine on the right track in this country. Specifically, it had to do with the design of the curriculum for training students, the selection of students, the learning methods, modeling, the role modeling of staff physicians to students, and methods of assessment for students. So it really transformed, and we all of us in medicine know the Flexner Report. It transformed the nature and the process of medical education in this country, eliminated the proprietary schools that existed prior to that, and established the biomedical model as the gold standard for medical training. So what about occupational medicine education? Well, AMA started in 1847, and in 2001 they started a journal. Flexner Report I've mentioned came out in 2010. In 1927, AMA assumed responsibility for residency training in hospitals. There really wasn't much residency training going on before then. Mayo Clinic actually was one of the very first institutions that had residency programs, even in the 19-teens. But AMA, by the late 1920s, was beginning to realize that it had a role nationally in very much in the sense that Flexner had done for medical schools. They were going to do this for residency programs and have been successful in doing that by, for example, creating the American Board of Medical Specialties. Now that has its own history, and I realize I'm oversimplifying this by saying it was the AMA that did it, but they were a major player in the creation of ABMS. They established standards for the examining boards, and they started to create examining boards. So one of the very first ones was one I mentioned earlier, made reference to, the American Board of Internal Medicine. The American Board of Surgery followed soon after that, and since that time there have been many, many other boards and sub-specialty areas that have been approved. There are now 150 that are officially sanctioned by the American Boards of Medical Specialties. With respect to our area, preventive medicine and occupational medicine, the American Board of Preventive Medicine was created in 1948. It took another few years to develop our specialties within that board, and I'm not really sure, someone in the room may know the answer to this, whether there were any actual certificates issued between 1948 and 1953 that were just general preventive medicine boards. There may have been, I don't know. In 1953, the first subspecialty board or specialty board within preventive medicine that was authorized was in aerospace medicine. And of course, the warriors had been very soon before that, and so there was a lot of people that were coming out of the military that were practicing in aerospace medicine that had moved this forward. Occupational medicine came a couple of years later, and finally preventive medicine public health in 1983. But occupational medicine training programs, residencies, were rather slow to develop. There were only 5 for many, many years. As you can see the list there in Cincinnati, Pittsburgh, Rochester, Yale, Ohio State University. When I was going into my residency, which was 1975-76 year, Irv Tabershaw happened to be at a conference I was at, and he talked about the analogy of the drivers in Maine who were trying to get to Bangor, and they stopped on a road because they were lost, totally lost, and they saw a farmer and said, "Could you tell us how to get to Bangor from here?" And the farmer looked at them and kind of quizzically and said, "You know, there ain't no way to get there from here." and Tabershaw used that analogy to say this is really the situation with occupational medicine in the 1970s. It wasn't very well developed. Well, that changed. In my case, in 1975-76, I was at the University of Washington. I was the second graduate of that program. And in that year, there was a delegation came from Washington to talk to us about establishing University of Washington as an educational research center, which I'll come back to in a minute, which they did. And that happened all over the country. ERCs, I think, were a stimulus in part to creation of programs that peaked in the late 1990s with about 40 programs altogether and close to 200 residents going through those programs each year. Unfortunately, since then, it's kind of fallen off. Research, the Occupational Health and Safety Act, Occupational Safety and Health Act, rather, in this country was published or established in 1970. to protect our most precious resources and to ensure that everyone in the nation has a safe and healthy work condition, and to preserve human resources. So they created, through this act, OSHA, NIOSH, and also another organization you don't hear a whole lot about, the Occupational Safety and Health Review Commission. In response to the act, with respect to NIOSH's role, they established educational resource centers around the country, initially 9, and that was over time expanded to 18 that you can see in different parts of the nation. There has to be an avenue for transmitting to practitioners and the public, and that started very early on with industrial medicine and its predecessors to that, which I'll come back to in a minute. But the Journal of Occupational Environmental Medicine started in 1959, if I remember correctly, yes, with Dr. Kammer, and progressed through that to today with a subsequent change in name to Journal of Occupational and Environmental Medicine in 1992. Dr. Brant Rauff is the current editor, and the prior editor is sitting right here, Dr. Lloyd Tepper. Glad you could be with us. Occupational medicine as a profession started in the late 1800s, as we've all heard multiple times over this series, with the railways, but also the merchant marine, the mining, the lumber, and the textile industries all set up medical services for their employees, because they realized that if they didn't do that, these people were going to be leaving work because of disability or death, and they wanted to do things to help prevent that. So that was really the birth of our field. Regional associations of these physicians were established initially in New York, Michigan area, Detroit, Central States, and Chicago, and then the National Association of Railway Surgeons that was mentioned earlier. So with respect to ACOEM and our centenary, which we're now celebrating, in 1915, the American Association of Industrial Physicians and Surgeons was formed under the guidance of Dr. Harry Mach. He served as the first secretary for the organization. The first president, which I'll come back to, was actually Dr. J.W. Ruski, and the first meeting was held in Detroit in 1916. So, in fact, this is the centenary of the first meeting rather than the establishment. And we actually, at the ACOEM board a few years ago, were debating as to whether we should make 15 or 16 the centenary, and for a variety of reasons we made it 16. So we're celebrating the first meeting of our association. Well, in the first 15 years of the association, we didn't have a category of fellow. The fellowship category came in 1931, and the first fellowship class, I don't see Natalie Hartenbaum in the audience, but I believe is still the largest class of fellows, and that was 62 that year. We had, I think it was close to 40 or maybe over 40 this year, so it was a pretty big class this year, larger than usual. We're normally about 25, but the biggest class was the very first one. In 1937, industrial medicine, which was mentioned earlier today, was produced to bring together 3 publications that existed prior to that, one of the American Association of Industrial Physicians and Surgeons, another, the New York document, which was the Industrial Doctor, and finally the Central States document. And Dr. C.O. Sappington was one of the editors of that publication. And it led later to other publications, including our own, JOEM, but also Occupational Health and Safety, the Archives of Environmental Health, and even some other ones were spin-off journals to that one. The conference, our conference was established in 1945, where we began to meet concurrently with the Industrial Hygiene Association and ACGIH, in addition to the nurses. So it became a national conference of all of the occupational health practitioners, and it was known then as the Industrial Health Conference. And that was really the first AOHC, if you will, that met. Now, each of these organizations had met separately prior to that. This is a meeting I went to, 1977, which was the first time I attended AOHC. But the meeting, as you can see there, continued to meet with the nurses until 2005 as AOHC, and we retained the trademark for that after 2005. And so Occupational Health, AOHC, is what we're attending today. The AAOM, the Academy of occupational medicine began under Dr. George Gehrman, who was a medical director of DuPont, as the first president. And it was mainly established to advocate for occupational medicine as a specialty because the predecessor IMA at that time, the Industrial Medical Association, many of those people weren't certified. So even though they had fellows, it was really the fellows group within that organization that began this new organization so that they could lobby the AMA and the ABMS to establish certification. Well, they were successful in doing that, and in addition to creating the journal, they eventually morphed into AOMA, the American Occupational Medical Association in '74, ACOEM in 1988. And the importance of ACOEM is that when it was created as a college, and I remember being at that meeting, I'm sure many people in the room were also, we merged to form the College of Occupational Medicine by bringing together AOMA and the American Academy of Occupational Medicine. The Academy had done its job, and the idea was we were going to be one specialty voice at that time. We did set up our headquarters. Initially, it was in a different place in North Chicago, but currently it's located in Elk Grove Village. Our membership has changed over time. It used to be corporate. Whenever my very first meeting, as I say, back in '77, I think pretty much all of the people you saw sitting on that stage were corporate medical directors. That's changed, and the corporate component of membership dropped from almost 50% back in 1992 to 24% in 2006, and then gradually rose. And you can see with private practice, that went from almost nothing in '92 to being over a third of the membership in 2006, and then has somewhat dropped back as private practitioners have more and more, not just in our field, but in many fields, have become employed by others. So many of the occupational physicians that might have been working in private practice back in the early 90s are employed by Concentra, U.S. HealthWorks, et cetera, or organizations like my own at Mayo. And so we have many people that are no longer in private practice. And of course, others includes government-employed people as well as academic people. So let's end this presentation with some of the people in our field who were pioneers in the past century. And I'll start with Alice Hamilton, who was with us earlier this morning. For those of you who were here, Judith was playing her part. But she began by exploring the hazards of lead and other heavy metals. And by the way, that included tetraethyl lead among the working class residents in Chicago and also throughout Illinois and Indiana in the day. She became an inspector for government, and she really laid the framework for occupational medicine in this country. She published a book on industrial poisons in 1925, which was succeeded by a book which was still one of my textbooks when I was in my residency, Hamilton and Hardy's textbook on industrial toxicology, and then in 1943 exploring the dangerous trades, which many of us have read. If you haven't, I'd encourage you to do that. Dr. Harry Mach was really instrumental in establishing our field from the point of view of authoring the first textbook and literally creating the AAIPS back at that time. One of the lesser-known things about what Dr. Mach talked about was health and productivity. And he includes in his book this graphic, which talks about how not to set up a company and produce goods, but that instead you need to have human conservation as the foundation for production in industry based on several criteria here that would lead to a healthy, energetic working force that maximizes production. So it's fascinating to me, a century ago, to see basically the same kind of processes that were discussed with us an hour or so ago by Dr. Lepke. This is not really a new concept. So who was Dr. Suresh Ruski? I had not known about his name before I did this presentation, but he was the first president of our association, and he was the governing person at our first annual meeting in Detroit. He was an author of medical inspection of schools. He was very much involved in that at the time. He produced several papers on physical examination of workers, industrial lighting, and a very explosive topic, the safe handling of TNT. Dr. Sappington, we've mentioned earlier, who served initially, again, this was history I didn't know, as a medical director in a variety of companies in California before being recruited by the National Safety Council in 1928 and becoming the author of not the author, but an editor, an important one, for industrial medicine. Authored a column there for many years, Dr. Pilgrim, that talked about his personal views on occupational medicine. And he was the first recipient of the Knudsen Award, and we'll come to that in a second. Dr. Gehrman, for many years we've had the Gehrman Award. We haven't given the Gehrman Award in terms of a speaker since we lost SOTAC about 5 or 10 years ago. But Dr. Gehrman was the DuPont medical director from 1926 to 1955, very long tenure. And he introduced standards to prevent bladder cancer among the company's dye workers. But I used the word controversial there because it took a while for him to do that. And for the first 10 years or so, maybe 15 years of his work with DuPont, he was much more of an apologist for this and said that there really wasn't much hazard associated with this. And it was really, it took people like Jim of the day to get to him and to get to DuPont to recognize the fact that, yes, this really was killing your workers, and we needed to do something about this. And so his career really made a turnaround at that point in time. He developed the Haskell Laboratory of Industrial Industrial Toxicology, which did much of the initial research on occupational toxicology in this country. And also, and I was pleased to learn this, he was really the first person that was a major medical director to establish a program to rehabilitate people with alcohol problems in industry. He was president of AAOM from 46 to 49. Now, this is a very interesting guy. Some of you know who he is. I'm sure Jim does. But he was the first director of the environmental cancer section of the NCI from 1938 to 1964. So he was in the field for a long time. And he was a real workers' advocate. He knew what was killing and poisoning workers. And he was heavily opposed. He worked for some period of time, both with DuPont and with government. But he was heavily opposed by industry and by government people who didn't want him to be talking about what he was talking about so forcefully at the time. But he was a very intelligent, very forceful individual in terms of expressing his views. And I think that he was a bit of a burr under the saddle to many of in that day, but he was an important part of what has made us occupational health physicians as we are today. He authored a book by the name of Occupational Tumors and Allied Diseases in 1942. Now, this is an even more controversial, probably the most controversial person we've got. A lot of good things have been said about him, a lot of bad things have been said about him. He was medical director for Ethel Gasoline Corporation and headed the Kettering lab at the University of Cincinnati that created one of the main initial residencies in our field. He was president of AAOM from 1949 to 50, but unfortunately, or fortunately, depending on your viewpoint, he was literally garroted by Deborah Davis in The Secret History of the War on Cancer. And if we had more time, T could tell us a lot more about that, because I know that's a special interest of his. But we did have the Kehoe Award in occupational medicine for many years within ACOEM, and that award, as some of you may have noticed, has kind of disappeared in the last 2 or 3 years as a result of this. Now, this individual is not a physician. Mr. Knudsen was not an occupational medicine physician, but he was a leading executive in the automotive industry, initially with Ford and later with GM, and he had a strong belief in the importance of occupational medicine. So he actually provided some funding for ACOEM back in that time to provide an award to the most distinguished physician in the field each year. And so the award is known as the Kehoe Award and recognizes the individual who's made outstanding contributions in the field of OEM, and that award is still in existence. He was actually a Time magazine person twice. once here in 1937, which was right around the time when he provided the award, and also about another 5 or 6 years later when he was working with the war effort as the Director of War Production. Dr. Kammer, we still have a Kammer Award, was the first editor, as I mentioned before, of JOM. He was medical director of Inland Steel, Union Carbide, and first professor and head of the Department of Occupational Health at the University of Pittsburgh in 1949, and president of the Industrial Medicine Association from 1951 to 1952. Harriet Hardy, 1905 to 93, was the second female professor at Harvard. So the first 2 Harvard female professors were occupational health physicians. I think that's something we should be proud of. She published delayed chemical pneumonitis occurring in workers exposed to beryllium compounds in 1946 with Dr. Tabershaw, and established the case registry for beryllium in 1952, and co-authored Hamilton book, Industrial Toxicology. Here's one that we can't leave any meeting without talking about on history of occupational medicine in this country, Dr. Shelikof. A wonderful guy. Had the privilege to meet him a few years ago, and he followed asbestos workers, as you know, for many years, epidemiological study, very large study, and the impact was to largely destroy that industry, and rightfully so, because of the illness and deaths that were arising from that. Finally, Dr. Marcus Key. I just mentioned him because he was the first director for National Institute of Occupational Safety and Health, and I think NIOSH is such an important organization that I wanted to mention him as the first director. He subsequently went to the University of Texas Health Center and practiced there in many years, and I believe was involved with their residency program. But he was president of ACOEM from 78 to 79. And that is it. So thank you all. Check my time, 12:01. I think we did all right. I'm around. Dr. Guidotti's probably around if anybody has questions on these things. And we appreciate your having participated, for those of you who did so, in all 4 of these sessions. But it's been kind of fun to do this. We've all learned a lot. Thank you.